Well, thanks everyone for hanging in there on this panel. I'm Dr. Ann Avery from Metro Health Medical Center in Cleveland, Ohio. I'm an infectious disease physician. I've been working in addressing HIV, both treatment and prevention, for more than 20 years now. And I'm going to talk a little bit about outcomes for the End the Epidemic initiative. So, as you already heard, the overall outcome is to reduce new infections in the United States by 75% and then by 90%. So essentially no new HIV infections. And then I think it's important to think about how we're looking at the outcomes by pillar. So there are 4 pillars to the End the Epidemic initiative: the test, treat, and prevent. And so what I'm going to talk about now is more, how do we really evaluate the effectiveness of the End the Epidemic initiative? So when I first think about the test initiative, I'm just have some bullets here. Test, well, that means that everybody knows their HIV status. However, I think there are some caveats here that how often do we need people to test to know their status? So if somebody has more risk, they should be tested more frequently. If they have low risk, they just need to get tested once. Treatment, certainly we want all patients with HIV to have an undetectable viral load and to be on effective HIV treatment. So how do we measure that? And then with the prevent pillar, we want all persons at risk for HIV to be protected from new infections. And so how do we determine who that is and how we get them protected? And then the respond pillar is different from the first 3, in that it is really more a public health response. So our needed services rapidly deployed in outbreak situations. So there are some considerations that I've been thinking about when it comes to these outcomes. The first consideration is, who's the denominator here? Well, when we look at testing as an example, how do we get an accurate denominator? I'm at Metro, so it's easy for me to look at the Metro Health population. It's harder for me to look at the Cuyahoga County population. But in order to really get an accurate denominator of who's been tested, then we need to look at the entire population at risk, which I think is Cuyahoga County. With PrEP, when we look at the outcomes of PrEP, again, the consideration about its denominator is important. How do we quantify who should be on PrEP? Is it anyone who is sexually active? Is it anyone who is sexually active with an individual who has higher risk for HIV? So men who have sex with men, trans women who have sex with men, commercial sex workers. What about the young adults, or just in general adults with sexually transmitted infections, or unplanned pregnancy? So we know that there are a wide variety of individuals who would benefit from PrEP, but measuring and quantifying who the true denominator is of needs PrEP is more challenging. And we need to really nail that down, or at least be open to suggestions on that when we are looking at how well we're doing in achieving the outcome of getting all individuals who would benefit from PrEP on PrEP. And then also looking at ways we can, what is PrEP? There are newer models coming out for prevention, as well as prevention for injection drug users. And then with the treat outcome, is it just those in care for the denominator? That's the easy one. That's what we often see. And I think that overestimates our success. Is it just those who know their status? So what is relatively easy to do is to make the denominator all those who are aware and living in our area in Cuyahoga County. But what about the people who haven't been tested yet? So these are just things that I want you all to think about as we talk about ending the epidemic, and really trying to get creative. We've learned that we need to identify who is missing and seek them out. We need new ideas, we need new partners, we need new venues, because I think oftentimes we are reaching people, the same people, multiple times rather than new populations. There are some areas where we've been having success in working in novel areas like the jail. So we do testing in the jail, we do care in the jail. Most of you who provide HIV care have had me send you messages that your patient's in jail. And we are going to be offering some prevention interventions in the upcoming 12 months in the jail. Working in the emergency department, the three big health systems all have some HIV testing in the emergency department, but I don't think any of our systems are comprehensive in their HIV testing approach. And we have learned that there are lots of people who only show up in the emergency department and don't ever make it to primary care or other areas. And so the emergency department is a key area for testing and for engaging people out of care. So working to engage our emergency medicine partners is important. Now, looking at mental health settings, community settings that are working with our priority populations, and then using social media. We've had some really exciting success in getting new people into HIV prevention through social media and advertising campaigns that have been surprisingly successful. So, getting the word out to new people and making it easy is important. Another consideration is that with viral suppression, particularly, we've got about 80% of our patients who are in care are virally suppressed. So we've got 20% that are not. And what we've seen is that it really takes a personalized approach to get that last 20% moving the needle at all. That when we thought we had a really easy slam dunk of getting individuals who were not suppressed, but they were coming into care, adherent to medication through a financial incentive and an adherence program. And even with a very good financial incentive for a 2-year time period, we only got about 40 to 50% of people successful. And it was a pretty small population. So, it was a chipping off of the iceberg, but it wasn't a slam dunk. And so, really, I think we need to think about how can we determine what will work for the priority populations and understand that there are lots of different things we need. We don't have a one size fits all solution. Another example that is an intervention we implemented where we had a clinic wide intervention a few years ago at our HIV clinic to improve the identification and treatment of depression. Well, we quickly learned that we needed to expand that mental health diagnoses to include anxiety, bipolar, and post-traumatic stress disorder. And now, as we are entering the epidemic intervention, we are looking at an intensive approach for patients with more severe mental health symptoms, specifically related to trauma. And so really trying to dig away at some of the comorbid conditions that our patients who have struggled with are exhibiting, are experiencing, and looking at new ways to treat those symptoms are also important. The good old fashioned give somebody Zoloft and a counseling is just maybe not enough. So we need to get creative and expand our options. I think with medication options, we've got some great new treatment options with long-acting injectables. In the pipeline are also implantables as well as long-acting oral options. But we need to look at those medications and options for both treatment and prevention to establish best practices for delivery initiation. Now, I've been very excited. I've had a few of my patients who have been really difficult to get on daily oral medication to be able to take that for a 6-week period of time as a lead-in, get themselves virally suppressed, and then be consistently successful. So we've got 9 months for some of these individuals with viral suppression using the long-acting injectables because we actually started them under the compassionate use program. So looking at ways to use these new tools to get more injectables, more implantables, more long-acting options to really free patients from the daily need to be adherent. And then vaccine studies. There's some great new ideas using the mRNA vaccines. Moderna has launched vaccine studies. So we have the tools to end the HIV epidemic. I think we have the measures of ending the HIV epidemic, and now we just need to work together and really pull it all off. So I'm happy to be a part of this panel and hope that we can have some great discussion going forward. Thanks.